Nice.
Anybody catch that musical special last night, Lady Gaga? And
Yeah, part of it.
that was really good.
I taped it.
Set such a nice.
I'm
mood.
having my. I'm sorry. Go ahead, Ron. Go ahead.
No, that's fine. I'm finished. Hi, Alan.
I'm going to have my son come over tonight, and he is going to watch with me for the first time Fiddler on the Roof. He has.
Oh, wow.
I've seen it, I think, 12 or 15 times. I lost count, but he's
Right.
developed an interest in his Litvak heritage on both my side and my wife's side of the family. And I think it's going to be an interesting eye-opener for him to see Chaim Potok as Tevye. So we're going to have fun. It's every time I see it, I get something out of it. It's just a remarkable musical that is ageless. So that should be fun.
So, Alan, here's a dream that I have, because I find that in my teaching, I frequently reference Fiddler on the Roof. And I think that there is an adult education course to be developed on what you can learn about Judaism and Jewish values from Fiddler on the Roof. So
Absolutely.
maybe in both of our retirement, we could collaborate on that.
If I was a rich man.
But what's amazing about, what does he say, Myra? If he was a rich man, and he wouldn't buy jets and yachts, I'd have the time that I lack to
Sit on the eastern wall
and pray.
and pray. Absolutely. Yep.
So what does that tell you about priority Jewish values?
Yes.
Filling this chair that just happened.
Let's see. I see all kinds of folks weighing in here. Dale, hi. Barry Singer, nice to see you again. Sarah, nice to see you again. Vicky. Barry and I were together this morning at Torah study. Sarah and I were together at Musar.
You're a busy rabbi.
It's keeping us going.
Yeah. Yeah, the hardest part is when it's done and then I have to take all those recordings and upload them to YouTube, and it's just a time-consuming process. I think Craig's been on Zoom with me all day today. Long time no see. Did you get some lunch in there, Craig?
I just made it under the wire.
Oh, funny.
So, I like to start on time, but I also want to give people a minute or so to find us.
Rabbi, can you see us?
Who's us?
John and Leanna.
Oh, yeah, we see you beautifully. You got that pretty mirror with the lovely chandelier. It looks very elegant at your house.
We never come in this room except for during Zoom meetings.
Oh, I see. Is that your actual house, or is that a background?
No, that's our house.
Oh,
Yeah, it's our house.
Yeah.
nice.
Rabbi Koppell,
I know sometimes people put up these different cool backgrounds, but it is fun to see.
That's our remnants from moving from Georgia here.
I see.
Georgia has a different kind of style.
Yes, it looks like plantation style there.
We kept one room to remind us
It's
of
our
living in
Georgia room.
The Georgia room. Oh, okay.
We come in here to go to Georgia.
Georgia's always on our mind.
Up. Here comes Owen.
Mm-hmm.
Owen was on Torah study this morning. Everybody's
Really?
Good.
everybody is very committed. I appreciate that. Hello, Betsy. How are
There's
you?
Betsy.
Hi, I'm good.
Good. Nice to
Hi,
see
Betsy.
you. How are things in your world?
Oh, they're chugging along.
Yeah,
How about with you all?
we're doing great. Felix, another refugee from Torah study. I'm having deja vu.
Like, what time is this really?
Seriously. All right. Well,
I'm going to log back in because I can't get video again. So
yeah. All right. Well, okay. Who's got the dog in the background?
I do. I'm going to go banish him.
Or just mute.
Yeah, I'll mute her.
My pet is a fish, many fish in a pond.
Nice.
Well, unless it's a piranha, we should be in good shape.
If it's a piranha, it doesn't matter. It doesn't make noise.
So I do want to put up our list of resources, which is a little bit expanded from last time we met. So let me just cut and paste that.
Where is that in the chat?
I'm going to put it in the chat right now.
Why can't I?
There you go. Everybody see your chat there? So the books are all the same we discussed last time. I did add Katie Butler, the book that Dr. Fischler was recommending, and all of those links. And is everybody who is on this call now, did you all receive emails about Finish Strong? Were you on the distro list for Finish Strong?
Yes.
Yes.
Was there anybody who did not
I
receive?
don't remember that I did.
I'm not sure if I am or not.
So
I'd have
that's
to check.
Myra and Sarah.
I don't think I got it either.
That was Jay. Okay. I'll check you on the distro list because Dr. Fischler has a whole bunch of resources that he's going to be referencing as well. So at the conclusion of this conversation, once I download and upload the recording, I can send you the recording for today, and I'll send you this list of resources, and I'll also send you Dr. Fischler's list of resources. So, so with that, I wanted to begin with a poem that is referenced. Let me get the books. It's referenced in the book. She doesn't quote the poem, but she references it on page 125. It's a poem by Jane Kenyon called Otherwise. And I think it's very beautiful and will set the tone for our conversation here. Oh, hi, Mom.
Hi there.
We're just getting started here. I'm going to read a poem by Jane Kenyon that was referenced in the book. It's a beautiful poem called Otherwise. I got out of bed on 2 strong legs. It might have been otherwise. I ate cereal, sweet milk, ripe, flawless peach. It might have been otherwise. I took the dog uphill to the birch wood. All morning, I did the work I love. At noon, I lay down with my mate. It might have been otherwise. Ate dinner together at a table with silver candlesticks. It might have been otherwise. I slept in a bed in a room with paintings on the walls and planned another day just like this one. But one day, I know it will be otherwise. So I think that book is an important reminder of why it's so important that we're having this conversation, because we know that we can't count on every day being as beautiful and perfect as today, as this moment is. And we know that someday for each of us, it will be otherwise. And we want to have as much control as we possibly can about that otherwise. With that, I'm going to turn it over to Dr. Ron Fischler. He's going to kind of give us a summary of what we've already discussed. And obviously, some of you were there. All of you have access to the link of that, but just the executive summary to kind of remind us where we're picking up the conversation.
Thank you. So we covered a lot of ground last time. By this author, Barbara Coombs Lee, who started her career as a nurse, later became a nurse practitioner, which is kind of like a physician's role, went to law school and ultimately became an advocate, and then led an organization called Compassion and Choices which is the major advocacy organization for something we'll go into a little more today called medical aid in dying, which is a legal option for end-of-life care available in about 10 municipalities around the country, but not Arizona. So you may remember that she began with two stories. One of Otto, a gentleman who was in his 60s, who kind of plodded along with his life, was a heavy smoker and died of emphysema, died like he lived without any in a rather miserable and lonely way. You might imagine that his family would have considerable guilt after his passing. Contrast that with the story of Nate, who was a teacher in his 70s, who also died after a chronic illness, congestive heart failure, had a supportive doctor who understands Nate's desires to avoid heroics at the end of his life, allowed him to die in peace. Nate was a very reflective person. He made time with loved ones during his whole life, shared with them how he felt, received letters from students, and had a peaceful and comfortable death. And that set the tone for the book. How do we want to envision our dying and death from the context of how we live our lives up until that time? All lives come to an end. And the first part of the story was overcoming our stigma for considering talking about this subject, which is hard for people in our society. That led to discussion of goals of care conversations about what we would want at the end or near the end of our lives, what we wouldn't want, and to explore those wishes, share them with loved ones, record them, and make them available to people. And those things might be specific, like CPR. It might also include things like other aggressive interventions, feeding tubes, various other things. So we can decline care, we can withdraw from care, we can even forego such things as eating and drinking at the end of our lives if we so choose. These conversations, these goals of care conversations, ideally are had with a physician and with family. Medicare pays for having these conversations. Advanced directives, which is another terminology for this. It's also called a living will, so the terminology is a little confusing, but those all refer to specifying what your wishes are at the end of your life. You're also encouraged to appoint someone in case you can't speak for yourself. It could be a spouse, it could be a child, it could be a friend, but someone who is going to be able to advocate for you if you can't for yourself, who knows your wishes and can speak those to the medical staff that otherwise would have to make decisions about how aggressive to be, because our medical care system, rightly or wrongly, the default is do everything. So if you don't wish to do everything, you have to say no thank you and have your proxy, your appointed person, your medical power of attorney, say no thank you on your behalf. This is not what they would have wished for. Partner with your doctors. Doctors, and we'll continue this a little bit today, you know, that you select because of their humanity. And these may have been slightly different criteria than you might have used to select doctors earlier in your lifetime. You need your doctors to provide you the information about the conditions that you may have. And most of us will have the opportunity to have a diagnosis and then have a period of time averaging about 2 years between the diagnosis and the end of our lives. So knowing that, you need to rely on information that your physician provides about what you have its nature, how it's progressing, where are you in the trajectory of that illness, so that you can make your own decisions based on your wishes. The other book that we referred to that I put into the reference list is Katie Butler's book. So just as Barbara Combs-Lee comes to this from a healthcare perspective, Katie Butler is more of a patient advocate. She's a journalist who interviewed some 600 patients at the end of people at the end of their lives, and came to her understanding through that. They're slightly different, but cover the same subject matter in a slightly different way. As pointed out in the introduction, Dr. Haider Warach, who is also a physician who's written about end-of-life issues, noted that when you first sit down to talk to your doctor, most doctors aren't really prepared for this. They're not trained necessarily. We certainly found that true in the survey we did of Arizona physicians, that few reported having been trained in how to conduct end-of-life conversations. So that it's somewhat foreign territory. But he found that most docs, appreciated being led by patients through this and would respond appropriately. And if not, encouraged people to find a doctor who would for this chapter of their lives. It could be a gerontologist, it could be someone familiar with slow medicine, which we'll talk about in a few minutes. One of the other things we talked about is that it's important to transform our notion of what hope is, from one that starts off being hope for longer life into hope for peace, relief of suffering, reconciliation, forgiveness, acceptance, gratitude, and all of those things necessary to bid what he calls she calls a hero's farewell. And then finally, palliative care versus hospice. Palliative care, this relatively new specialty, about 12 years old, that's designed to help people navigate between the time they receive a terminal diagnosis and the time of their beginning of their dying process, which could be 2 years, as we said. And the purpose is to have a medical person to work with to help you decide which treatments you're going to accept and which ones you're not going to accept, to help balance, to make sure that in the time that you have left, that you maximize the quality of that time and not compromise the quality of that time by your pursuit of longer life, if that's not your primary wish. If your primary wish is to have a comfortable and peaceful ending to your life. So palliative care is more of a longer term idea, spanning perhaps a couple of years. Palliative care docs are in hospitals. Primarily, there are a few in outpatient settings. Some primary care docs, family docs, gerontologists may play this role very admirably for patients, very adequately. Hospice is for the last 6 months of life. Traditionally, people waited to go to hospice until the last week of life. Again, people are encouraging people to use this last period of time to prepare them and their families, and that can be done with longer time. Medicare covers hospice. Hospice in most places requires that you forego life-prolonging medications, and that's a bit of a holdup, although there are experiments which have been done which suggest that there is a compromise to be struck. I don't know to what extent that's available in Arizona, but so with that as an introduction, are there any questions about anything that I just said? And then we'll head into today's session. Okay. So
Betsy has a question.
Oh, Betsy, yes. You're muted. Betsy, you're muted.
Oh, Bonnie has to unmute me. Okay.
Okay.
So, I understand how this is set out for people who have chronic illnesses or illnesses that are going to have, a limited time span. But what would also be helpful, I think, would be a discussion for people who are in relatively good health, who just may have an accident or may have a stroke or something where they don't have a long period for preparation. And, I was just thinking about this after our last session. I mean, I have a internist that I've seen probably for 30 years who's at Mayo Clinic. And I mean, we've never had this discussion, and I've been healthy, so there really wasn't any point to bring it up. But if somebody has something that happens unexpectedly, what kinds of recommendations do you think should be done proactively?
So let me just share a brief vignette involving a cousin of ours. We had Shabbat dinner. The next morning, I get this urgent call that something terrible has happened to her husband. He was sitting next to me. We were joking at the table the night before. It turns out that he had had a massive stroke, a bleed, a hemorrhage into his brain. He was in the emergency room. There had been signs of increased intracranial pressure, and the damage was considered extensive. And the question the emergency room doc had asked was, did they want him transferred to a neurosurgeon who could do some surgical procedures to remove some of the clot, but not change the fact that severe damage had been done? I asked her, what would he have wanted? And she said, well, we discussed it many times, and he would not want to live under circumstances that would make his life that he couldn't recognize people, he couldn't do things for himself, which sounds like it was described that he would be. At that point, she decided not to transfer him and instead have him admitted to hospice, where she notified his kids. They were able to fly in time. They had about a day and a half before he passed quietly. So I do think that one can anticipate one's advance directives and say in fact, most of the time when you do a will and you do a living will as part of that will, they say, if I am in circumstances that are not likely to get better, and I'm not able to do certain things, relate to other people, I could pull down the text of ours, but it's a fairly clear description of, and you can modify that how you wish, but that you would, under those circumstances, if you couldn't, my mother-in-law says, if I can't recognize all of you, and if I can't manage myself in the bathroom, then I don't want to go on. She's 96. So, it's sort of like each of us has our own sort of way of stating how it would be. In Gavandi's book, he gives several examples of his father, who I think wanted a beer and be able to watch sports, and then he'd be okay. But if he couldn't do that, then don't prolong his life. So I think that it's important, and whether you start this process at age 60 or 65 or 70, it would seem that at your annual visits with your doc, that there should be an opportunity to review and update your advance directives. Now, if you get diagnosed with a serious illness, then it becomes much more specific, and you can go into further details. In a couple of minutes, I thought maybe we could use the COVID situation to kind of talk a little bit about a specific circumstance of advance directives.
So if I could ask then, so it sounds like this is an important conversation to have with one's doctor well in advance of there being any specific life-limiting diagnosis. What about our healthcare proxy?
Same thing, deciding who could speak for you if you aren't able to speak for yourself. And sometimes that might be a kid, but sometimes not. Sometimes it might be a spouse, but sometimes not. So it's really who would honor your wishes.
So so I have an advance directive and all those kinds of things. So is it appropriate then to just like give a copy to my physician? Is that what you're saying?
Yes. And electronic medical records do, in fact, have places to keep advance directives.
I thought that the state of Arizona also has a statewide depository of these sorts of documents.
They do. So there was an attempt to try to create something. It's in the Secretary of State's office. The problem is it's not so readily accessible. So people have suggested that if you're in the last 6 months of your life, that you obtain an orange form, which in other states is known as POLST, P-O-L-S-T, physician orders or patient orders for
life-sustaining treatment.
Life-sustaining, exactly, sorry. Medical orders. So it comes by different names. It has to be accessible. So the whole idea is that it's on the refrigerator, so that if you're found down and 911 is triggered, then they will see what your advance directive is. And if you did not wish to be resuscitated, then if they had access to it, that they would not do it, or at least advance directives are still guidelines. There are situations, maybe Alan can address this, that come up where either because they're not accessible or for other reasons, someone in a first responder role might conceivably ignore advance directives. But the more people that know what they are, the more likely they are to be carried out.
So I saw Dr. Molk put something in the chat. Mom, you were applauding. Were you trying to raise your hand? Because I was just thinking as we're talking now about the fact that, you know, my father had a DNR, and yet in that moment of urgent panic when he stopped breathing, and the neighbor took it upon herself to call 911, and my mom couldn't readily lay her hands on that DNR. And so the whole medical torture establishment, if I might say, came into play, and he got to the hospital and was resuscitated and put on a ventilator, and then we had to fight with the hospital to remove him from the ventilator. Is that an accurate summary, Mom? Anything you want to add?
No, it's not an accurate summary at all.
It's not an accurate summary. I misunderstood.
We went to the hospital. First of all, I could not find the do not resuscitate.
That's what I just said.
That's true. I was the one who called on 911.
I thought Norma called.
Oh, no, I called. She told me to call 911. I think I called her and she told me to call 911. But we got to the hospital and they explained that he wasn't doing well. And I wanted to say, forget it. And my two of my grandchildren were the first people there because they lived near me. And they were hysterical and said, you have to give him a chance. But it was agreed that 3 days, and after 3 days we could take him off. And that's exactly what happened, which was not bad because it gave us a time to get used to the fact, and it gave you a chance to get here while he was still breathing.
Right. So it was the grandkids then who kind of overrode his desire and your desire and whatever the advance directives might have been.
That they were hysterical. And it as I said, it wasn't terrible because it was 3 days and it gave everybody a chance to get used to the idea.
All right, Dr. Molk, did you want to say something about what you wrote in the chat?
It's not uncommon for people to show up in the ER in what we call extremis, meaning in severe distress, end of life. Some people use the term circling the drain, and there are no advance directives, and family members are unclear as to what the wishes were of that person. That person is not responsive. Sometimes we do, in fact, briefly do resuscitation. We may intubate them, we may start treatment, and the family has explained in no uncertain terms that this is probably going to be futile. We don't expect a good response, and we can reassess in 12 or 24 hours whether we should discontinue resuscitative efforts and take the patient off the ventilator. And that does happen quite frequently. It ideally shouldn't happen, but it is a form of doing what I would call damage control in a situation where this patient should never even have ended up in the emergency room in the first place. Unfortunately, that ends up happening all too often. Always going back to fail to have the conversation, fail to have advanced directives. It really, in this setting, it always goes back to that.
So Betsy, does that answer your question?
Partially, I guess it would be worthwhile to initiate something and have something in my medical file because there's nothing there now. So I mean, that's assuming that they can get to that physician. I mean, obviously the other people who are specified in my advanced directives probably should have copies of those, which they don't. So I think that there are some things that can be done proactively to kind of make those bases touch.
So you have a medical power of attorney?
I do.
And is that person aware of the kinds of issues that Dr. Fischler was talking about of, you know, I want to fight for my life. If my
I do. I mean, but you know, my kids are out of state, and even if I sent them the copies out of state, they don't have them now. But I mean, they're aware of what my wishes are. But probably it would be wise for them to have a set of documents.
Yeah, I think so.
They don't have.
When David was diagnosed with the terminal diagnosis of, I think it was the renal cell carcinoma, he and I had done very specific advanced directives 5 or 6 years prior when we were both in perfectly fine health. And what we did was we sat all of the kids down in the same room at the same time. We gave them each a physical copy of the advanced directive. I want this, I don't want that. Under these circumstances, I would want X, you know, as far as artificial nutrition, hydration, ventilation, surgery, et cetera, et cetera. And it was very helpful to have the conversation with all of them in the same space at the same time so that they all knew exactly what both of our desires were. And the hope was then to mitigate against what my mom is describing, where somebody rushes in at the last minute, you know, you got to do something, you got to do something.
I have a question, a little unclear. With what Dr. Molk said, I mean, suppose somebody collapses and you don't know what the cause of it is at that moment. Are you not supposed to call 911 if somebody has an advanced directive? Because maybe it's something that could be fixed quickly, or, you know, how are you supposed to know?
I can tell you that when we don't know, when there's a question, when it's unclear, when we have no paperwork, and when you're sort of caught in one of these situations where you either have to act or the patient is going to expire pretty quickly, we do tend to err on the side of, okay, we're going to resuscitate till we get more information. We can always withdraw treatment at a later time. So we do tend, even though sometimes a tough call, we do as a general rule tend to err on the side of doing some initial resuscitation, unless it is obvious. And I can tell you of one patient I had who rings a very powerful bell, was a terminal AIDS patient who literally was just having what I called agonal respirations. He looked like a concentration camp survivor. The family were not very helpful, but it was clear he was unresponsive to anything. He only had gasping respirations. His blood pressure was very palpable, and he was in the dying process. And in that type of situation, it is certainly reasonable to, if you recognize that, to tell the family this person is in the dying process. We should allow what's called A&D, allow natural death. And in that situation, it is perfectly appropriate just to do comfort care and It turns out that particular patient died within about 15 or 20 minutes, and it was peaceful in the end.
But as a family member, you're with the person, they collapse. How do you know when you should call 911 and when you shouldn't, if they have an advance directive?
And if you know the advance directive, this is an older person who's chronically ill or who's near the end of their lives?
Well, somebody who, like Nancy Leonard was saying, maybe collapses and you don't know what it is. Is it a stroke? Is it something? You know, how do you know what to do?
It's certainly reasonable if there's a level of uncertainty. If this were, for example, the final chapter of a true terminal illness, then calling 911, in my opinion, would not be the right approach. However, if the person is still doing reasonably well, in spite of the fact they have a terminal illness, and they still have a reasonable quality of life, and they may have a reversible condition that occurred that caused them to collapse, then that's reasonable. They may have had, for example, had an arrhythmia, which is an irregular heartbeat, which can be reversible. And in those
low blood sugar in a diabetic or something.
to call 911, the person can be assessed in the emergency department and to see whether or not we are dealing with a potentially reversible brief issue rather than this is truly end of life. If you're not sure, it's still reasonable to call 911, and it can always be reassessed that very same day.
So I think the answer that I'm hearing, Sandy, is it depends. You know, are you talking about a young, otherwise healthy person who mysteriously collapses? That's a very different situation from a much older person with a serious medical diagnosis. Mm-hmm. There are a couple of questions in the chat room before we move forward. Myra wants to know, can a person ask not to go to the hospital?
Absolutely, and that'll come up in our discussion around COVID. So maybe we'll do that right after this, if that's okay.
Okay, and Felix wants to know, is there a medical directive app that you could put on your phone?
Well, that's an interesting idea. Never heard of it. But here's the thing: you've got your password in your phone. So if you're the one who collapses, how is anybody else going to find your advance directive in your phone app?
That's true.
So I don't know. Interesting kind. You could certainly have a format that could be, but I don't know about that's necessarily the best place.
I just looked it up. There actually is an app called My Directives Mobile, MY. It's an app you get on Apple, and it looks like it's got some useful stuff on it. I personally have a look at it.
Interesting.
It's available.
There you go.
Maybe it goes around the password or something. Maybe it just shows up, populates. I don't know.
Personally, I've not downloaded it, but I'm considering doing it.
Interesting.
I wanted to just take a moment and address other types of advanced planning from the religious perspective. One of the things that is helpful to consider is, what are your funeral and burial desires? It's an overwhelming process enough for family members when you die, let alone for them to have to be second guessing. What did you want in terms of, did you want to be buried in a shroud, or did you want to be buried in street clothes? Did you want to be cremated? Did you want to be interred in a coffin? Did you have any preferences about what that coffin might be? Did you want a funeral service that was separate from a graveside service? So you can do your loved ones a tremendous, tremendous favor by thinking about and making those decisions now. It's even possible to prepay for these services, because a traditional Jewish funeral and burial can run probably $8,000 to $10,000. So that's a fair amount of money for somebody to have to come up with on the spur of the moment, and then try to think through all of the myriad of decisions that are associated with the burial process. Some people, it's important to have a shomer, that is a guardian, somebody who's going to stay with the body from the time of the death until the burial? Do you want the traditional tahara, washing of the body, to take place? These are all important considerations. And do your family, your loved ones a favor and think through those. Sit down. If you want to have a traditional funeral, sit down with the funeral director, calmly and dispassionately go through all of the options, just like you're going to articulate from a medical perspective what's important to you, articulate from a religious perspective what's important to you. There are people who even specify if there's a particular rabbi that they want to do the service. Now, it doesn't say the rabbi will be available, but I have gotten calls from Sinai Mortuary from people that, frankly, I don't even remember where our lives intersected, but for whatever reason, they told the mortuary, when my time comes, try to reach Rabbi Koppell. We would like her to do the service if she's available. Myra.
Okay. I didn't think of all the marvelous things that you brought up now, but I have told my children that I want to be buried in a plain wooden box.
Okay, so that's a good first step. But there's so many decisions that need to be made, and it's very hard to make them in the midst of emotion and grief. And just to point to the situation my mom was describing, then there can be conflicts among family members. One wants one thing, one wants another. So better to forestall as much of that as you can.
Another thing is I have bought a plot already.
Yes. So all very helpful things, because when someone's dealing with the pain of a loss, the last thing they need to be doing is shopping for funeral plots.
Rabbi Koppell, I'm this great believer that saying goodbye is the ultimate act of love. And to take it a step further with regard to what you mentioned, making it easier and less painful for your loved ones at the time of death is also a huge act of love.
Amen.
To the stress, burden, and pain, make the stress, burden, and pain of death easier by doing all this preparation that you're referring to.
Good. So I'd like to move into the text a little bit. We were talking about slow medicine, and if you read the book, it was just a fascinating story with that finger injury, where rather than rushing in immediately to do hand surgery, the person was allowed their own body to heal itself. That was something completely unimaginable to me as I was reading the book. I live in that culture of, you get hurt, you go to the doctor fixes it. The idea that our bodies can do much of the healing on our own was a very unique concept. I wanted to particularly call your attention to page 113, if you happen to have the book handy. Just a reminder that we are the customers, and we just because the doctor makes a recommendation doesn't mean we have to say yes. I'm not going to read the whole long list there, but it is a very interesting and worthwhile list to look at. What are some of the things to ask yourself, to think about before you just reflexively, viscerally consent to a treatment? What is the goal? What proportion of people receiving this treatment actually achieve that goal? If it's going to extend my life, potentially by how much? And what are some of the risks and side effects? How is the treatment going to affect my quality of life? Sometimes the treatment can be worse than the disease. And in fact, is there a chance it could make it worse? Are there other treatment options? And I think maybe most importantly, what happens if I decline this treatment or any treatment? So just remembering that we do have the authority and the control to make those decisions. And I think Dr. Fischler was going to talk a little bit more about slow medicine and this idea of partnering with our doctor, and you wanted to talk about some of the COVID specific considerations.
Right. And just to continue on that theme, on page 125, so the idea behind finding a doctor who practices what's called slow medicine, meaning just don't reflexly jump to the standard treatments, tailor the treatment to the specific needs of the patient. And that's the basic principle. Understand the patient and recognize that the relationship with the patient in terms of building trust is important, that communication is the foundation of any of that relationship, that you're going to be there to support and advocate for that patient to make sure that their wishes are met, and that kindness will be the transcendent sort of quality that you bring to it. It's a concept that's been written about in a variety of sources. It's at the foundation of gerontology. Family practice certainly has this as pretty close to its base in terms of philosophy. It's the difference between treating a disease and treating a person who has an illness or a condition. And these things, I think, become of greater concern toward the end of our lives. So I think that's the concept. Take the time, if between the diagnosis and the treatment, to think about these questions, to ask these questions, maybe to have someone with you when you go, maybe record the conversation, because questions will come up and it's so overwhelming and we have so many emotional responses to being told certain things. So it's important to take things slowly and methodically through this process. Are there any questions about, I would be curious to see, maybe with a show of hands, how many of you would you say have physicians that have these qualities currently? I see 1, 2 on the second page. Let's see how many's up there. Maybe 3, maybe 4. So the majority of you do not.
Ron, I don't know whether I do or I don't, because I've never had a conversation.
You've never put it to the test. And that's what I think she suggests, is that you initiate the discussion. You don't wait for physicians. Because as I said in our survey, when we surveyed 600 docs, how often do you initiate the conversation? It almost never happens, even when somebody's on death's door. So it's up to us to initiate the conversation and create some hypotheticals. If I was diagnosed with a condition that ultimately would claim my life and I decided to not undertake certain treatments, how would you feel about that? And she suggests several of those kinds of questions to help you elucidate which folks you might put on your list. You know, I think the current COVID situation provides an opportunity for us to consider some of these issues in a very current way. So if I may, what I'd like to do is spend a couple minutes talking a little bit about that and then reflecting back on what we've just talked about. So COVID, we've become very aware of the nature of this virus, how contagious it is, the fact that people may not have symptoms, that most people have very mild symptoms, but a small but important minority of people, maybe about 20%. Well, actually, we don't know how many people, because we don't have a good what's called denominator. We don't really know how many people have COVID out there. We know the ones who get to the hospital. We know the ones who have tests, who are lucky enough to have tests, because tests are still not widely available. We know firmly how many are admitted, how many go to the ICU, and how many die. We know that the percentage of people who die and have severe complications of COVID tend to be older people with chronic illness. And we know that if you're admitted to an ICU and put on a ventilator and you're older with chronic illness, your chance of coming off is very low. And your chance of continuing life in the way you knew it before is very small. Now, we can't be too specific because whether you're talking about Italy or China or New York, these are fairly recent and numbers that are hard to hang one's hat on. Sometimes the uncertainty of the numbers makes it impossible to make a decision. But I think that for an older person who develops COVID, first of all, less than 1% of the population at present is likely to get it if we're good with social isolation, social distancing. Of that group, your chance of having a mild disease is probably 80%, even if you're older and have risk factors. So it's the small group of people who get sick around the 5th to 7th day. But around that time, things progress quickly. And you get a pneumonia, and you can't breathe, and your oxygen drops, and something needs to happen. So you may call 911 or not. It depends on your circumstance. But assume you call 911, you're brought to the ER. There you're evaluated, and you may be offered admission. You're entitled to either say, yes, I'll come in the hospital, or no. If you don't really have someone who can care for you at home, you may want to be in the hospital. On the other hand, one of the sad parts about COVID is that all hospitals now have restrictions on visitors. So there are no visitors allowed in hospitals, which puts the medical staff in the position of having to be the ones to comfort people at the very end of their lives and be on the one to call the families and facilitate the discussions. Any of you saw that program last night. It was just so chilling and poignant. So in a sense, the issue is if you have a mild case, you don't need to worry. If you have a severe case and you're older with risk factors, you got to ask yourself the question, do I really want to subject myself to being in the hospital, being admitted to an ICU, being intubated, and I suppose having CPR? And the chance of surviving CPR in this circumstance with any quality of life is next to zero. So that essentially is the issue with COVID. Now, Compassionate Choices, among others, but that one is one I'm familiar with, and I'll put the reference on, or I think I did already, has a COVID-specific advancce directive. If I'm lucky, I might be able to share the screen. Let's see if I can do it. Give me 1 second.
We believe in you.
Let's see. So there's, this is it. Let's see. Okay, and then how do I push share? Can you see it?
Yeah, you're sharing. You have to open the document.
It is open.
We can see the file, but we can't see the advance directive.
That's weird. So you can't see Compassionate Choices COVID-19 Advanced Directive?
No, we're looking at your list in your file.
You're
we have
looking at my
ARMA,
list in my file.
AHA,
Okay.
Right.
I
So
wonder how I do that.
You just open the document.
That's what I just did. I clicked on it. I opened the document. I see the document. Do you?
No.
No.
So you don't. All right. Let me try one other thing. What if I move it to this screen? Open that. What about there? Can you see it now?
Can you minimize the list?
Minimized list.
Yeah.
Can you see it?
No, we're just looking at your list of documents.
Okay, so that's the problem.
If you minimize the list, then maybe we'll see the document itself.
Are you working on 2 screens?
Well, I wasn't until I did a second ago.
What happens, what happens if you minimize the folder? Is the document, I wonder if the document's behind it.
I minimized everything. Sharing is paused. Bring your shared window to the front. I'm going to stop the share here for a second because I'm not getting anywhere with it. Let me try one more time. Before I do that, and if not, I'll just read you because it's pretty short and I could just read it to you actually. You still can't see it, right?
Sorry, no.
Okay, so here it is. If your oxygen levels are dropping, do you want to go to the hospital or would you prefer to get non-invasive respiratory care at home? So if you basically say, look, I've had a good life. I don't want to die alone in the hospital. If I get COVID and it's mild, I'll stay home and I'll take care of myself. But if I can't take care of myself, do I want to have hospice come out and help me the last couple of days of my life at home, pass away from COVID? Or do I want to get to a hospital, see what I've got, see what they tell me? Maybe I'll get better in the hospital because at least half do. If you're not able to to receive non-invasive respiratory care at home, do you want to go to the hospital? Yes or no?
Is this the document? Is this the document you're looking for?
No, but that's okay too. This is Katie Butler's translation of this in plain English.
Oh, okay.
So look at the paragraph there. If I'm seriously ill from COVID, I understand that a visit to the medical center hospital may be able to provide some pain relief. I would welcome that. But if these services can be provided at home, I'd like that. Do keep me out of physical pain. Do not agree to tests that would results meaningless given my desire that treatments might be burdensome. I'm having trouble reading this myself. If I go to the hospital, I don't want a resuscitate order. I want to be a DNR. And I think it says down here about ventilation. I don't want to be, there you go. Okay. If I go to the hospital, what do I, if I don't want to go to the, oops, sorry. If my condition deteriorates to the point where doctors are recommending I move to an ICU for ventilation, please ask my medical team to provide comfort care only, known as comfort measures. Now, I did speak to the vice president of hospice, and she did Hospice of the Valley, and she did Rachel Burns, who's a member of our temple. And she did say, as of last week, that it's possible to get emergency hospice services at home for COVID. So they could provide oxygen, pain relief, all of that stuff. Try to secure hospice and palliative care at home. I prefer to die in the place that has become my home if it's possible to do so. I do not wish any attempt at ventilation. So this is an example of her advanced directive for herself. The one going back to the one from Compassionate Choices, and I would just, you know, if you want to be ventilated, are there any guidelines how long you want to stay on the ventilator? If your kidneys shut down, do you want to be put on dialysis? Because as many of you may know, once all this cascade begins to happen, your organs begin to fail. And so your kidneys fail, your heart fails, your brain fails. You are paralyzed and sedated when you're on ventilation. So it's, and as I said, you are, and people who are ventilated for COVID, it's not unusual for older high-risk people to be on the ventilator for weeks, so that it's not something that's fairly quick. And a high percentage of people wind up with chronic lung issues as a result of that. So it's not if I make it through it, I'm going to be fine. So the point is that there are examples, Katie Butler being one, and Compassionate Choices having this sample advanced directive that you can fill out, cross out, put in what you wanted. but it's a situation where I could be doing pretty well today. I could be mildly ill tomorrow, but in 7 days, things could go downhill in a hurry. And it's an invitation to think about, what would I want if that were going to happen?
Several years ago, I spoke to the doctor, and I told her that I didn't want to be on a ventilator. And she goes, "But you'll die." I says, "I don't want to be on a ventilator." And again, she like, "But you'll die." So I'm not so sure she would listen to me.
Well, it's true. You would die.
I know that.
And you could be kept comfortable, and you could die at home with family around, or you could.
Goes back, sorry, Ron.
Yeah, go ahead.
It goes back to how physicians, to this day, it's the old mindset of death is the ultimate enemy to physicians. Death represents the failure of a physician. It represents the failure of medical care. And physicians have become so obsessed with that they fail to see the big picture, that life does have a beginning, a middle, and an end. And there is something called a dignified, peaceful death. There needs to be a re-education, retraining, and a change in the culture of how the medical profession thinks. And that change is underway. We are working on it.
So if there are no more specific COVID-19 questions or comments, I'd like to ask Dr. Molk to take us back to chapter 8 in the book, which deals with dementia, which if we think COVID-19 is a frightening diagnosis and a frightening way to die, I will say that I found this chapter on, was it the 7 stages of dementia that she mentions to be completely haunting. So yeah, so Dr. Molk is going to walk us through that. I've mentioned his book, Saving Lives, Saving Dignity, which we're going to get together and talk about on May 13th, yet to be determined if that will be in person or on Zoom. But when you read his book, you'll see that one of the contexts, other than his experience as an emergency physician that led to his authoring this book, was also his experience with his own mom. So he's in a unique position, both personally and professionally, to walk us through what the progression of dementia can look like and what some of the decision points are, some of the decisions that, again, we might want to be thinking about now so that we can have as much control as we can over what our lives look like in the sad event that we find ourselves moving through some of these stages.
Thank you, Rabbi Koppell. I'm going to do something that Dr. Fischler did earlier. By a show of hands, I'd be interested, could you raise your hand and let me know who of you have either seen or lost a family member or a friend or a loved one to dementia?
Well, seen for sure.
Quite a show of hands. So you can see how frightfully common this is. And I think that all of you who have raised your hands will agree that it is an extremely difficult and painful journey for both the patient and for the loved one. I will tell you that this chapter 8 is superbly written. It really summarizes the dementia dilemma, as I can call it, magnificently, from the stages to some stories, and as well as describing what should we do, what's the best approach. I'm not going to talk about what causes dementia. There may be a familial component. The fact is we don't really know. I'm not going to talk about treatments because there really are no effective treatments. There have been drugs out like Namenda and Aricept and Exelon. None of them have really been shown to be beneficial because, unfortunately, this is a progressive downhill neurological disease, unlike multiple sclerosis, which often people do get good remissions. And make no mistake about this, it's an equal opportunity disease. It affects the most brilliant of people. It affects college professors. It affects physicians. It affects scientists. I can tell you we recently lost one of our most wonderful orthopedic surgeons here in Phoenix a couple of months ago. His name is Dr. Bruce Mallon. He developed Alzheimer's shortly after he retired. Just a wonderful, brilliant guy, brilliant orthopedic surgeon. But he became a victim of this disease as well.
And a mensch.
My late uncle, my mother's younger brother, Lionel Borowitz, was truly a rocket scientist in Israel. He worked at the Weizmann Institute, and whenever you asked him what he did, he was sort of quiet about it, but we knew he was involved in some very high-tech development of nuclear energy and so on and so forth. And he developed Alzheimer's and a horrible downhill course. I'm going to briefly talk about my mother. And some of you have heard the story, but I'll be brief about it because there are stories described in this book that are very similar. These stories often have a similar tune to them. My mother was a delightful 75-year-old, sharp as a tack. She was living in New Jersey near my brother, and one day she got lost on the road. No big deal, anyone could get lost. She got lost a second or third time and ended up in a bad neighborhood. And then my brother then called me and said, there's something wrong with Mom. And I went through the classical stages of grief, denial, the anger, the disbelief, the bantering, etc., etc. But it was evident that something had set in. She had a workup with a neurologist, and it was clear that she was in the early stages of Alzheimer's dementia. She then got, I brought her to New Jersey. I said to my brother one day, I think it's time for me to take care of Mom, and I flew her out here. It was clear that she wasn't going to be able to maintain her life on her own. My wife and I both work. We had to find her a place that takes care of a memory center, which is like a very politically correct and inaccurate way of describing an Alzheimer's facility. But we had her in Koppell. At that time, Koppell was able to handle her until one day I got a phone call from Koppell saying, we need to talk to you. You need to come over right away. And I did. And they said, your mother has been going around hitting and punching other residents indiscriminately. I was like totally taken aback because my mother in her normal state she wouldn't harm a fly. So I was forced to take her into a geriatric psychiatric facility at St. Luke's because they made it very clear that she cannot be kept there in this condition, that other family members were very upset, and understandably so, of having their loved ones being slapped and hit by my mother. And unfortunately, we came to a crossroads. And the crossroads was, she was either going to continue along this haphazard behavior that included unexpected, unexplained, violent outbursts, which, by the way, common in Alzheimer's, and we had to place on some sedation. So the tough decision was, can she be kept the way she was, which certainly was not acceptable, or were we going to turn her into a bit of a zombie, which is what we ended up doing. And at least she was no longer aggressive or agitated. The journey then became progressively more painful because she started to stop recognizing me. Classical downhill course. She started to develop some Parkinson's, which a lot of people with Alzheimer's do. And then one day I had what I call the crystal ball epiphany. I do talk about it in my book. As I was sitting visiting her, and every time I went over, I dreaded it. I absolutely dreaded. I'd go 3 or 4 times a week. She was ultimately in a place called Encore Senior Village. Driving there, I could just feel, oh God, I got to look at my beloved mother in the state. She probably doesn't know who I am. Maybe she does. It just tore a hole in my heart. Every drive there to this facility, and I would spend half an hour with her. And then the epiphany came up when one day I thought to myself, what if when she was 75, before she developed Alzheimer's, I looked at her and I had this crystal ball and said to her, Mom, 5 years from now, this is what you're going to look like. What would she have said? And the answer would have been very simple. She would never have wanted that. Her words would be, push me in front of a train, throw me off a building, push me off a cliff, put a pillow to my face and suffocate me. She would never ever have been wanted to be left in that situation. So that takes me to, we were fortunate that we both my brother and I had her power of attorney, and we knew what she wanted. She would never have wanted that. So ultimately, when she did develop a bad case of pneumonia, it was simple. We got hospice and she passed peacefully in 24 hours. And I will never forget the drive back from the cemetery, Mount Sinai. I was sitting with my brother in the car, and I looked at him and I said, is it just me, or do you feel a huge sense of relief now? And he nodded his head and said, absolutely. The take-home point for me for that was, invariably, when death is prolonged and there's suffering and the end comes, there is a sense of wonderful relief. It's almost indescribable. Very, very different to sudden death. This is expected death. Sudden death, someone, God forbid, gets killed in a car crash, is doing fine, has a massive brain hemorrhage from an aneurysm. This is day and night. And we're not going to talk about sudden death. This is expected death, where the end invariably is a relief, even though there's a sense of loss. So I'm always reminded that you can be assured that if you've been suffering a long time, when your end comes, your family will feel a sense of relief and appreciation that you're no longer suffering. So I just want to further elaborate a little bit on the book, having told my story about my mother. All of you who like to do memory improvement, like to join the AARP and all do that, great, keep it going. It's good for you. It's great to stay sharp, but also be rest assured it does not guarantee you from getting Alzheimer's. So my biggest take-home point from what she talks about here, she talks about that 1 in 3 adults are going to get dementia, and as you get older, it's going to be higher.
If you live long enough,
it's going to be higher. So we need to live our lives and prepare as if we're going to get dementia, one way, shape, or form or another, and absolutely include that in your advanced directives. Include the dementia/Alzheimer's component. Alzheimer's, the most horrible thing about it strips you, and she talks about it beautifully in the book and gives examples, how it strips you of your dignity. And we all treasure our dignity. We value our dignity. You take an elderly person and you tell them you're not safe to live by yourself in your apartment. We're going to put you in a retirement center. So many of those people, of these elderly people, or you take away their car or their car keys, feel that you have stripped them of their dignity. And then they give up. And then it's a downhill course from there. This is what Alzheimer's does. It strips you of your dignity in the most unthinkable ways. There's a great description that she gives over here of a lady named Sandy Ben. And we can talk about that. Ron, this falls into the medical aid in dying. Sandy Ben was a woman who was evidently very brilliant, and she kind of stockpiled medications. She was a stockpiler, and she was able to, at a point in time when she still had enough insight, and that's a key part, the insight part, that she was able to do her own end of life by taking medication that she stockpiled, mostly barbiturates. Something I totally support. Not many people think about that. It's a bit of a slippery slope. And unfortunately, medical aid in dying does not, unfortunately, provide for dementia. Ron, I wish it would. I wish that we could come up with some addendum to it that would say, if somebody has in their advanced directives that should they reach a point where they become incontinent, don't recognize family, all they do is sit in a chair all day or lie in bed all day, that maybe a surrogate should be allowed to administer medications. But that is such a slippery slope from a religious, ethical, medical, legal standpoint that I don't know if that's ever going to happen. I would like to see it. I see it as humane. The other thing that I thought was fascinating about how that was written in this book is she talks about a video supplement of your advanced directives. I remember that Howard and Sharona Silverman did one of those at Temple High not too long ago, and it was great. I'm going to be doing the same thing. I think it's important to truly tell people about your loved ones, your surrogates, whoever's going to carry out your advanced directives, about the fact that you do not ever want to be in a position where you're have totally been deprived of your own self, of being your former you, and that you're now basically someone who is, for lack of a better description, somewhat in a vegetative state. That there should be some kind of escape route from that. Again, a lot of it is a slippery slope, but being very proactive in your advanced directives, and I know that Barbara Combs-Lee highlights this magnificently in Chapter 8, that make it clear, make it that there's no second guessing, and do a video of what your wishes are, and have your family become aware of it, distribute it to whoever your loved ones are, so that they know that in no uncertain terms. If anyone has any other questions, I think I've babbled on long enough. Please fire away.
If you look in the chat box, Myra had a couple of comments looking to really distinguish, I think, between dementia and Alzheimer's. And Owen is asking about planning in practical terms, which I think Dr. Fischler is going to address in a couple of minutes when we look at chapters 9 and 10, what's going on now and taking control.
Yeah, let me just.
I'll wait on mine.
You know, Alzheimer's can have some lucid moments. My mother's most painful lucid moment that I recall happened when she was in the early stages, and she disappeared. She walked out of the house, and like many Alzheimer's patients do, they wandered off. And we took us about a half hour to find her. And when she came back, I sat down with her and please begged her to try not to walk away without us accompanying her. And she looked at me a little tearfully and she said, "I'm so sorry that I'm becoming a burden on you." That was an incredibly powerful moment when I realized that, in fact, people with Alzheimer's don't want to be a burden on their family. They don't want to be a burden on others. None of us really do. And that's why it's so critically important that this gets included in your advanced directives. As far as Alzheimer's is just one of the forms of dementia. There are other forms which are actually more pronounced and severe, with an even shorter, even a worse timeline can occur in some people even in their 40s and 50s. There are other forms known as frontal lobe dementia. Alzheimer's is by far the most common. And unfortunately, there is no treatment for any of these. It's all just predominantly comfort care. It is, however, sometimes important, though, if you have an elderly person who becomes confused or not acting right, to distinguish between what's called dementia and delirium. Delirium is a reversible medical condition that causes agitation and confusion. And that can be anything from pneumonia, lack of oxygen, urinary tract infection, and other forms of abnormal blood work, meningitis, for example. These are all potentially reversible. Dementia is much more gradual and much more insidious. Delirium is much more acute, and usually it's reversible, and people with delirium should get treated, because most of them are treatable and can return to a relatively normal state.
I want to underline what you mentioned about urinary tract infections, because this is something that we see at the temple a lot, is a dementia, the appearance of dementia that is not a true medical situation, but is a consequence of a urinary tract infection. So if you are caring for an older person and they start to exhibit signs of dementia, it's really important that as part of that diagnosis process that they be checked for UTIs, because I have personal experience as a rabbi of people who spend prolonged amounts of time in memory care units who ultimately were diagnosed and cured by treatment of the UTI. So that's just been a fascinating thing that I've learned through anecdotal experience.
And Rabbi, as long as they're diagnosed, they can turn around really quickly. You give them a couple of doses of antibiotics IV, and the next morning they're back to themselves. And it's almost like giving someone with low blood sugar orange juice with sugar. They're hypoglycemic, they improve dramatically. This is the same thing with elderly people with UTIs who are diagnosed, who should be diagnosed with what's called delirium rather than dementia. And it's a fairly straightforward workup.
So the other thing that really struck me in reading the book and looking at these different stages of what I would call decline as dementia progresses is her guidance that we need to think through for ourselves individually, if we had access to medical aid in dying, at what point, or even in terms of an advanced directive that we would give to a proxy, at what point we would want to say enough is enough, and that point might be different for each individual. And I'm wondering too, how often you might see that someone says, well, I would never want to live if X, and then X occurs, and guess what? The desire for life supersedes the limitation that when we're younger and healthier, we think it's unimaginable to live in that situation. And then we find ourselves in that situation when the choice is truly between life and death. Suddenly, we're ready to live in whatever capacity we find ourselves.
I
Just
think
to
it's
highlight,
difficult to actually see what people look like with dementia, with advanced dementia. And as I could see by show of hands, many of you know that once you've seen that, it's a picture is worth 1,000 words. It's very easy to say, good grief, no, I don't ever want to be in that situation, sitting in a chair, rocking back and forth, not knowing anybody, having to be fed. And then the decision is so clear.
Yes.
Mhm. So let me just highlight what Alan just said, because I think the approach to dealing with somebody with advanced dementia comes down to declining certain levels of care. If, for example, in end-stage dementia, the person is not eating, rather than insert a feeding tube to allow them to eat, you might say, I'm not going to prolong their dying. Or a person who develops pneumonia, rather than subject them to continued prolonged dying, will opt to withhold antibiotics, provide comfort care, and allow them a natural death. So it really comes down to declining care that may be offered, even somewhat reflexly. The whole idea of stockpiling medicines, anybody read the book or see the movie Still Alice?
I read the book.
You may remember she attempted to do that as well, and then when the time came, she didn't remember what it meant. It is not something, unfortunately, that's addressed in medical aid in dying. It is something that is being discussed in Canada, where they, in addition to medical aid in dying, they also have euthanasia. But I don't think it's worked out as yet. But I think they are far more progressive than we in addressing some of these concerns. Interestingly, in Teutsch's, the article on Jewish views of ethics, he includes the possibility of euthanasia for certain situations, including advanced dementia. But it's currently not a legal thing to do anywhere near here for the foreseeable future.
Any other questions or comments on the theme of dementia? Owen?
Yeah, so it sounds like the advanced directive component and dealing with Alzheimer's and or dementia is, it's not so much that you could say, if I get this way, I'm gonna stop eating, because you may not remember that that's what your decision was. If I hear you correctly, it is that it's advising, directing our caregivers in advance that you don't want X, Y, and Z procedure under the following circumstances. And in a way, it sounds like that's not any different from what the advanced directives would be if you were compos mentis. It is that you're saying it, if I'm not capable of making that decision and speaking for myself in a competent way under these circumstances, then those decisions still stand. And that's really what I want.
Right.
Am I hearing that correctly?
Now, some have advised using something called the Dementia Provision. And again, Compassion and Choices has a sample dementia provision, and I'll add that to the list here in a minute. In Arizona, they talk about a power of attorney for mental health. So dementia is, I think, lumped rightly or wrongly under a mental health thing. And so it may be an additional addendum to your medical power of attorney to include such things as advanced dementia. So check with your attorney on that one.
Got it. Thank you.
I'll get you a copy of the advanced directive for dementia.
Thank you.
So Dr. Molk, what strategies can you recommend for those who might have a loved one whom we believe may be in the early stages of dementia and are in total denial about that. I know that that's something that I see again in my work, where people have serious concerns about a spouse or a parent who they see significant changes, but can't even have a conversation without the other person being in rage and denial.
Well, the first thing to do is to get a thorough evaluation. You have to confirm the diagnosis. You need to see either an internist or a neurologist or a geriatrician. This would include a certain amount of blood work, a thorough physical exam and imaging, CAT scan and or MRI, and do certain testing. There are various neuropsychological testings that confirm the diagnosis, and that's how we confirmed the doses with my mother several years before she passed away. So once you have a diagnosis, and it's usually fairly easy to confirm, the thing to do is just do the best you can with what you've got. Sometimes it takes a third party to speak to the individual who is in denial. Try and get as much advanced directives as you can, given the stage or the early stage. See a lawyer. This is a situation where you do want to see an estate attorney who can certainly help with that. And the estate attorney can work with the gerontologist, coming up with proper advanced directives, and then going from there. And then then it involves, my recommendation also is you can contact the Arizona Alzheimer's Association. They are an excellent resource as well. I've been to a couple of their meetings. They are really well organized. They have excellent different forms of support group. And also remember that the caregiver, the family members can benefit from also from attending meetings and becoming educated on what the best thing is to do given that situation, and then trying to create as good as possible a quality of life, given doing the best you can with what you've got, kind of thing. Does that answer your question?
Yes, it was fantastic, and I think the critical thing is the first step of not trying to do it alone, but engaging the medical community.
And an attorney. I put in the conversation project thing on dementia guidelines and a reminder to include mental health power of attorney as well.
So I wanted to say something. Can I?
Please do, yes.
Oh, okay. So, some of you may know, and some of you may not know, that I'm a forensic psychologist, and I recently was contacted by Navajo County. They had picked up a woman who was driving erratically, who turned out to be really delusional and was demented. And she had a court-appointed attorney who interviewed the woman, and she presented as very, very lucid, but she was also assaulting. She had spent, I don't know, a few days in the emergency room. They couldn't find a bed. She was sent to a nursing home where she started assaulting other residents, and there was a big problem. So sometimes before the power of attorney provision kicks in, it is sometimes necessary to go to probate court and have a guardian appointed. And I think that it's somewhat difficult to know when there are conflicts between the person who is still relatively lucid or presents as if they are fairly intact, but they're not capable of making their decisions, that sometimes it's necessary to have the probate court make a decision as to whether this person needs a guardian or not. Mm-hmm. And that's very, very seldom addressed. but I've probably seen 2 people in the last year where there's been a conflict between the family and the patient as to whether or not they were competent to make their own decisions, in which the court had to get involved and have an independent evaluator assess that need for that individual as to whether or not they were in need of having a court-appointed guardian. So I'm just raising that because it does occur.
Wow.
And I think then there's the problem of having a younger person having signs of dementia, a child of us older people, perhaps. And it's a difficult problem.
So, not hearing anything else on dementia. Thank you very much.
One more thing.
Alan. Yeah, please.
It's a crossroads of medicine, ethics, and law. And you know, sometimes it requires a combination of all three to find the most ideal approach for that particular given individual. Every person is unique. Every person may not. This is not a one-size-fits-all situation. And I definitely think sometimes the legal intervention or the legal component of what needs to be done is every bit as important as the medical. Thank you.
Good. I want to make sure we give Dr. Fischler some time to talk about taking control and what's going on now. Where do we go from here?
So I'll be brief on this. I think that taking control means what we've started here, which is really becoming more willing to look at this chapter of our lives, to think about our options, and to take steps to assure that we clarify what our wishes are, make our wishes known to our loved ones and our physicians. Find physicians who will advocate for us, find a friend, a relative, a child who will advocate for our wishes, because we are concerned as much with how we end our lives as much as we are with how we live our lives, in the awareness that life is limited. So some of it is empowering yourself, as I've mentioned on a couple of occasions. Katie Butler's book, The Art of Dying Well, is all about how to be an empowered advocate for the kind of death experience that you want. And she goes into great detail, so I won't cover that. So let's talk for a couple of minutes about end-of-life options as they exist. So we've heard that when you get close, you can decline certain forms of care that otherwise would be offered as a default. And you would decline them based on what your goals are, because you're an advocate for slow medicine, taking the time to deliberate before accepting the course of a treatment that's offered, and having a physician, ideally, who is on board with you in that approach. So you can decline treatments, you can take all treatments, you can check into palliative care or hospice. At some point, you can voluntarily decide to stop eating and drinking. And if you do that, if you stop drinking, within about 7 days, you'll pass. During that time, you can be sedated if you're under hospice care. And there's also something called palliative sedation, which is putting you in that sort of sedated state, and then not providing food and fluids during that period of time, allowing the same course to unfold, a few days in which your body basically dies. So enter another option, an option called medical aid in dying, which is a compromise. It doesn't serve all of our needs. We've heard how it doesn't work for Alzheimer's, for example. It arose in Oregon in the 90s, in 1994, and then it was passed in 97. It's now in 9 states, plus the District of Columbia, and in all of Canada. Here are the key elements of it. It is designed to help terminally ill adults have another option. You've got to have 2 doctors confirm that you're in the last 6 months of life. You've got to be a resident of the state in which it's legal. You've got to be able to give informed consent, meaning you have to be of sound mind at the time that you decide to invoke this option and all the way down to actually taking the medicine. You have to be able to self-administer the medicine. It's given as a slurry. It cannot be given as an injection. It can be pushed through a feeding tube if you have such a thing. But you have to be able to self-administer it. To assure that you are not requesting this without having thought it through, you have to make 2 oral requests, and there's a separation of a number of days between these requests. And then you have to have a written request. And in Oregon, there's a 15-day waiting period. That's now been rescinded by a new revision to that law. That was the first revision to this law that's taken place and that has been enacted. So in Oregon, if you are likely to die in the next 15 days, you don't have to wait the 15 days as specified. The death certificate would list the underlying illness as the cause of death. It removes liability for doctors who participate, for families, and this is not considered suicide when it comes to life insurance or other kinds of insurance kinds of policies. Families and beneficiaries who might benefit if you passed cannot be the witnesses on your request for the use of this. And in 20 years, there have been no abuses of this law. Now, this law appeals to, I think is helpful to many, but actually a very small percentage actually opt to use this law. Only about 0.5 of 1%. So about a little under 1% request it, and about half to 2/3 actually utilize it. But what it does is it allows someone who's near the end of their life to plan the time of their death, to plan the people that they want present, and to take a medicine that will reliably cause them to go to sleep and not wake up. This was probably popularized the most by Brittany Menard. You may remember, maybe 5 years ago, a 29-year-old woman with a glioblastoma. She had surgery and radiation, and nothing worked, and the tumor progressed. She had just been recently married. She opted to see the Grand Canyon and moved from California, which was her residence, to Oregon so she could take advantage of this law. Her mother and her husband continued the fight for this law and actually were responsible for the passage of the California law. Other states nearby, Colorado in particular, also passed the law relatively recently, and Maine, where I spend a fair amount of time, passed the law last year. So I am leading an effort to try to get a law like this in Arizona. We're certainly looking for people to help us. So if any of you are inclined to become involved, and involvement means writing to legislators, holding receptions at your house now with Zoom, but later in person, to educate people about what their end-of-life options are and about this particular addition to that list. So we're certainly looking for various kinds of help to achieve that. So I think what we're talking about when we talk about advocacy is helping others achieve a peaceful death. And we've done that in Temple High through death cafes. We've had lots of permission from Rabbi Koppell and rabbis to conduct discussions in this. There's opportunities to serve as a hospice volunteer. or one can become part of the advocacy group that pushes for a new law in Arizona. And by discussing this law, helping to foster the discussion around what a comfortable end of life might look like, whether or not we had this law or not. So in essence, I think that's kind of where we are. We don't expect much to happen this legislative session, especially not since COVID. If there's a shift to the left in the Arizona legislature, it may be possible for a bill like this, which has been introduced many times over the last 10 years, to be finally heard. As you may know, the Arizona legislative process means that the party in power has the chairman of the committee in which these bills are heard. If the chairman is of the opposite party, and unless there's bipartisan support, these bills typically get filed until the end of the session, and then it's too late to discuss them. So that's typically what happens to bills like this, and that's what's happened in the past. So if the composition of the legislature changes, that might change. Otherwise, we are also seeking bipartisan support, et cetera. So that's pretty much all I had to say about advocacy, Rabbi.
Thank you so much. So I'm sensitive to the time. I want to make sure we allow for any final questions. Let me briefly address Myra's question in the chat. Myra asked about Jewish religion and suicide. So the Jewish religious perspective on what we are talking about traditionally walks a fine line of saying we are not permitted in any way to hasten a death. So ingesting something or giving somebody something to ingest that would cause them to die more quickly would be prohibited according to the traditional halachic perspective. If, however, we are giving, let's say, medication for pain relief that might have a side effect of hastening death, then that is halachically permissible. And Dr. Fischler referred to an article by Rabbi David Teutsch on this theme. I had disseminated it previously, and I will send it out again as a follow-up to our discussion today. What I think is the most cutting-edge thinking on moving away from, he refers to that distinction as a halachic fig leaf. And I think it's a really perfect way to put it. And he kind of says, based on his own experience, I think he's talking about with his grandmother, it might have been his mother, I think it was his grandmother at the end of her life. And the fact that to his understanding, she never would have wanted to continue to live in the form in which she did live. And the fact that there was no medical aid in dying available to her. He's trying to move the ball forward in terms of Jewish thinking. I think it's going to be like so many other things, Myra, where it depends who you ask. 2 Jews, 3 opinions. I imagine that the more traditional the rabbi, the more they're going to adhere to the traditional halachic standard. But within the non-Orthodox world, there is some forward movement in saying that really the halacha was developed at a time when death was a much more natural part of life. And the challenge that we face now is that we have medically, we have medical means to extend life beyond anything that any of us would recognize as a desirable quality of life. And that's why the halacha needs to evolve to address the contemporary medical situation. So that's a quick response. Let me unmute you, Myra. Does that, maybe you need to unmute yourself. No, can't hear you, Myra. Oh, there you are.
Thank you.
Okay.
It's like you have to eat ham if there's nothing else to eat.
There you
Right.
go.
Right. On that subject, people have pointed out people like to call medical aid in dying assisted suicide, and opponents to it certainly regard it that. However, there are some unique distinctions between suicide and medical aid in dying. In suicide, the patient wants to die. In medical aid in dying, the patient wants to live, but is dying of some condition or disease. In suicide, the means are often impulsive and violent. In medical aid in dying, they're thought through and they're peaceful. And then finally, the mourning. With suicide, it's often a great deal of guilt that a family has to deal with. In medical aid in dying, it's often great relief that finally their suffering has come to an end. So I think there are some key differences between medical aid in dying and suicide that are worth bringing up.
I understand that lately, because of the COVID virus, that a lot of people are, whatever you want to call it, committing suicide. This is a problem that I hear about, and I see Alan shaking his head yes.
Really?
Well, I can just chime in here. I see suicidal patients in the emergency room on a daily basis. Many are genuinely suicidal. Many are gray zone suicidal. Many are just coming as an outcry for help. A small percent may just be seeking attention, but we never assume that. But I will tell you that I kind of saw this coming. In fact, one of the emails I get from one of my medical daily notifications talks about how COVID and depression is the perfect storm. It's quite frightening, actually, of how people who were previously depressed were doing well, that being in solitude could put them over the edge if they don't have support.
Disconnected.
And having issue with their businesses going sour, that could put them over the edge. So I unfortunately foresee that this increase in suicide as something that's likely going to happen unless people ask for help. And following when this COVID-19 virus finally passes, that there'll probably be a sizable amount of PTSD that people need to be seen for. So you're absolutely right, Myra. The rate, no one really talks about it, but I definitely foresee that there's going to be more suicide unless people get help.
So I'd like to say something. I have volunteered to do crisis counseling for the state of New York. There was a call that went out to mental health providers by Governor Koppell. And I can't tell you that there's been an increase in suicide. There's certainly been an increase in what we would call acute stress reactions and very possibly PTSD. I think because people are really feeling a sense of desperation and sadness and feeling a lot of anxiety and being overwhelmed. I think that there's been a lot of discussion about increased rates of suicide in the right-wing media. And Trump has even announced that in his daily press briefing, but I haven't seen any statistics if that's really true. I think there's a lot of people who feel acutely depressed with high levels of anxiety, a lot of acute stress reactions, and legitimate worries about how people are going to manage through this time. But I have not seen anything in any of the psychological literature, and I get emails daily from a variety of sources where anyone has really talked about suicide as an actual event, and that the prevalence of it has gone up during this period.
Thanks, Betsy. So again, we're just about out of time. I want to make sure everybody has on your calendar May 13th at 7 p.m. I think I'll set that up as a Zoom, and on the off chance that we're able to get together in person, that would be fantastically incredible. Betsy is also recommending a program called You Don't Know Jack about the work of Dr. Jack Kevorkian. So good recommendation. Does anyone have a final thought or takeaway about today or our previous session? What is one thing that you learned, one thing that touched you, one thing that you really want to make sure that you remember from all of this conversation? Owen.
It's our responsibility to guide our children on what we want.
Yes.
I thought I had it covered. I, done all the legal stuff and also had conversations with my children, but after listening to Ron and Alan, I've got some more work to do.
Thanks. Felix?
I just wanted to add a couple thoughts before we stop that might be useful to some people. Going back to the question of when a dear one shows early signs of Alzheimer's or dementia,
Yes.
what can be done? One technique that's been shown to be pretty effective in certain conditions where the person is very reluctant or resistant to accepting help or recognizing what's wrong with them, such as severe substance abuse, let's say, is the technique of group intervention, using the family and friends to come around that person in a sort of major meeting, a marathon meeting of a sort, and just pointing out to that person from all the different angles what is being observed, and trying to help that person then accept that they do need some sort of help.
Thank you. Great question.
The other that I want to just mention in terms of suicide and COVID is that, in my humble opinion, I think that people who want to rush back to having things open up, businesses open up, and for us to sort of ignore shelter in place, those kinds of precautions, social distancing precautions, are really sort of probably demonstrating some subconscious wish for mass suicide, because they're promoting high risk behavior that would inevitably lead to many, many more deaths. So, and if they're gathering with their colleagues together in one place, they're just maximizing the probabilities of dying there. So I don't think that can be ignored. That's what I wanted to say.
Other final takeaways?
I think both sessions have been extremely valuable to me. And I appreciate that we've had this from Temple High.
Thanks, Maren. I'll make the link available ultimately on YouTube also, so that you can share it with others.
I'd like to.
Thank you.
All right, so stand by for an email from me. I do want to thank Dr. Ron Fischler, Dr. Alan Molk for their tremendous support. And I'd like to conclude with a prayer, which I adapted from Rabbi Sidney Greenberg. Source of all life, we pray for life. Despite the burdens and the heartbreaks, we pray that years may be added to our lives, and also that true life may be added to our years.
Yeah.
Help us to enhance the quality of our lives, enriching their content, deepening their meaning. Help us to keep our minds alive. May we be open to new ideas, entertain challenging doubts, re-examine long-held opinions, nurture a lively curiosity, and add to our store of knowledge. Help us to keep our hearts alive. May we develop greater compassion, be receptive to new friendships, sustain our enthusiasm, grow more sensitive to the beauty which surrounds us. Help us to keep our souls alive. May we be more responsive to the needs of others, less vulnerable to consuming greed, more attentive to the need for community, and more devoted to truth. Help us to keep our spirits alive. May we face the future with confidence, knowing that every age has its unique joys and satisfactions, each stage of life its own glory. Help us to keep our faith alive. May we be sustained by the knowledge that you have planted within us eternal life and have given us the power to live beyond our years. Whether our years be few or many, help us to link our lives to the life of our people and to our beautiful tradition. Amen.
Amen.
Thank you.
Thank you all.
Thank you, Rabbi
Take care.
Koppell.
Bye-bye.
Thank you all.
Thank you, Rabbi.
Thank you.
Thank you, Rabbi.
All right, bye now.
Surprise.
See you soon.
No. I really do. Okay, we'll go pee.